Can you hear us, Ahmed?
Yes, I hear you very well, Doctor.
Okay. Why don't we go ahead with your talk? You have 8 minutes. I'll warn you at the end of 7 minutes, and we'll go from there.
Sure. Good morning, everybody. This is Dr. Ahmed Bafadel. I'm one of the cardiac imaging consultants that, as Dr. Tuju was saying, did some extra training in structural heart disease imaging for guidance of procedure and implantation of valve. So I have no disclosure. So our short talk today is going to be about the utilization of the imaging and multimodality imaging in TAVR and the journey of the patient through TAVR process from the beginning till the end. So I'm going to highlight the main imaging planning and utilization in this talk. So first of all, we're going to go the pre-TAVR imaging assessment. So I just want to get the attention of the audience to this document, which is the consensus of experts on how we plan clinically and from imaging perspective for patient growth, go through the process of TAVR. That document was published in 2017, led by Dr. Catherine Odo. So you'll find in this document actually a good at least 2 to 3 checklists where we can find the beginning from clinical, from assessment of the symptoms, assessment of the patient condition overall, frailty, and etc. Then you go to the imaging section, you'll find this checklist where it has the echo, CT, MR, and all the imaging modality that you need to focus on, and what the information you need to get from the imaging department or your imaging colleague to plan your TAVR if you are an interventionist. So I just want to show this. I know it's a busy slide. I just want to show that it appears in your document. So then next is, it tells you here in the same document that if you're planning for TAVR, the main 2 imaging modality is echo and TAVR CT. So TAVR CT is the chest, abdomen, pelvis CT that you give contrast and you image the axis from the femoral up to iliac, aorta, up to the aortic root, and you see the aortic annulus plus the valve. And we all kind of familiar with this. So the echo side of it, which is actually the most important thing to decide, does this patient has a severe aortic stenosis? So I'll take like a couple of minutes to show some of the challenges that we face in echo when we decide about is this patient having a significant valve issue or not. The first of all, when we do an echo, we depend mainly on continuity equation, which actually have a slight variation or error, comes from measuring the LVOT diameter. The problem with this, if you look at the images on the right side here, right bottom, you can see this is a zoomed image on the long axis parastellar view, and you can see here the way we measure it in this view, actually not the true maximum diameter of an oval shape LVOT and annulus. So basically what we measure is the shorter axis from the LVOT. Remember, it's oval shape, and most of the time the ovality or the maximum diameter on the horizontal side that you don't see it in this view. So basically this is one of the challenges of calculating the stroke volume. Second challenge is to align your Doppler to the valve and the LVOT. So a degree more than 50 degree of angulation actually underestimate your gradient. This is another issue. And we see that most of the time. We're going to come to that in the next slide, that you have a valve area of less than 1 centimeter square, but your gradient actually is less than 40. And most of those people or those patients, they're called moderate aortic stenosis because most of the readers, they depend very much on the gradient rather than the other parameters. But we're going to see here. So the other challenge is assumption. An assumption of LVT is a circular structure, which is not fully true because it's an oval shape, as we see in the panel on the left lower. So I brought this study to show you. This is a group of researchers. They did reading about 3,500 echoes to confirm the basic knowledge, what we learn about, if you have a valve area, okay, look at here, valve area below 1 centimeter square, you should have about 40 mean gradient of pressure. But actually, what they didn't found this consistent in 2008, and we have this info for the last 20 years. So what they found is, so they imaged 2,500, about 2,400 patients. They reviewed 3,500 echoes, and they found that actually 30% of the patient, which is in this box, they have a valve area less than 1 centimeter square by continuity equation, which is validated by 2 readers. But the problem is, the pressure did not go up to 40. What they found is, actually the 40 millimeter gradient is correlated to here, this crossing point of 0.8 centimeter. So basically is not actually very accurate to have a 1 centimeter as a cutoff. But you can see also the 1 centimeter cutoff was correlating to 21 of pressure gradient. So the other challenge is low gradient
Ahmet, you have 1 minute
aortic
left.
valve stenosis. So we're going to go skip that. The butamine is one of the challenges to decide about pseudo aortic stenosis versus true severe aortic stenosis. And we now depend on what we add on is a calcium scoring of more than 1,200 for women, 2,000 on men on CT to decide. And this comes from this study. They did it on men and women, and they found this is the cutoff, which is actually with p-value of more than less than 0.0001, which gives you a very high correlation with severe aortic stenosis. This is to show in this slide that if you have 2 patients going for TAVR, one with right ventricular dysfunction and the other one with not, so the mortality or the prognosis is worse with right dysfunction, right ventricular dysfunction. The etiology of low flow, low gradient, this is one of the biggest issues, that if you have this issue, but those mainly patients, they have thick ventricle, they have other valve issue. That's why you don't get the full stroke volume that we actually depend on. On CT, we have our checklist, as Lubna showed, the
Ahmet,
slide
you
that
have,
we did before.
Why don't you summarize in 30 seconds?
Okay, so quickly, if you're not able to do a CT scan because your patient has a kidney issues, so you can do an MRI and go from the MRI and measure. You are very correlated to the CT scan. One of the points, you have to calculate your LVOT and systole, not in diastole. So we'll skip the 4D CT when you do the valve assessment. This is to show that if you have a fibrosis, an MRI that's having correlation with high mortality. Amyloidosis, you find it in up to 1/3 of the patient of TAVR, and that's based on autopsy study. So 3D printing is one of the tests that you can use for utilization of the technology. And in conclusion, having a heart valve team is very crucial to have a good outcomes. Normal flow, low gradient aortic stenosis, you find it in 30% of your daily patient. However, this need a high professional team to decide about is it symptomatic and severe. Multimodality imaging approach, it should be considered in complex patient, and post-TAVR 4D CT is very useful to decide about issues with the valve. Thank you.
Thank you very much, Ahmet.